Sorry for the delay, Natasha. You should be ready.
No worries. Just let me know when I should start coming in.
Yeah, I'll do that. Okay, could you try sharing and let's see how it goes?
Sure. Can everyone see this?
That should be good, I think.
Great. And I'm assuming my audio is good for everyone as well?
I hope so, yeah. We don't have any actual amplified audio here, so it's going to be a little bit quiet maybe, but I think we should do fine here.
Okay. Should I start? Or just wait?
Yeah, I think we can get started.
Okay.
Okay, let's go.
Great. Hi, everyone, and apologies, I can't join you all in person. I can't actually see anyone in the room, so I'm not exactly sure who I'm speaking to, but for those of you who maybe have not met me yet, my name is Nat. I'm a technical officer in the newly formed Data, Digital Health Analytics, and AI department within WHO headquarters. So I'm based in Geneva. I am the one coordinating the Smart Guidelines program of work within WHO. So I support teams within WHO to create Smart Guidelines content, and then I work with countries to adopt them. So yeah, please let me know if you have any questions, maybe at the end of the presentation. And apologies for those who may have heard this presentation before already. But essentially, the WHO's work in digital health are really informed by the global strategy on digital health, which is formulated with member states. And one of the key strategic objectives is to advocate for people-centered health systems that are enabled by digital health. So a lot of our Smart Guidelines work is really centered around this strategic initiative. And so the way we see it is right now with a lot of countries going towards digital transformation, or even countries that already have a lot of digital technologies in use already, there's always this gap between the health program managers and the technology partners that are responsible for translating national policies into a digital solution. And so we see a lot of countries facing struggles with difficulty scaling existing systems that they have already adopted maybe for one area or one limited scope. There's also a lot of issues with lack of interoperability, which of course prevents scalability. There's also a vendor lock-in caused by having a black box digital system that becomes very difficult to maintain, and it's very unsustainable as countries have limited resources for health. And there's also just a lack of shared language for program needs with digital systems. So oftentimes we see technology partners will work with maybe a small group of M&E people or people who are interested in health data specifically, and they design these tools that they expect clinicians and health workers to use, but that's not necessarily what the public health need is in the country. And so there's a lot of gaps there. So the smart guidance is intended to help provide that shared language amongst these different stakeholder groups. And then, of course, when it comes to health data, and this room is very familiar with the issues around lack of interoperability, but what we want to work towards is really this idea of collecting once, using many times. So generating data from EMR and labs and point of care systems, but then the secondary data that it comes from that can be used for supporting case surveillance, health systems monitoring, clinical decision support services, or patient-mediated exchange of personal health records. And so reducing the data collection burden on health workers so that they can actually just focus on providing care. And so the Smart Guidance program of work provides documentation and guidance that are really intended to intervene at these two steps of the software development lifecycle. So when you're gathering user requirements, and then when you're designing and adapting technologies and developing them. So the Smart Guidance provides the health content areas, so the clinical information, as well as the digital functionality that should be in a digital system. Like, for example, it should send reminders or things like that. So we outline what those requirements are that's determined by the health program to help support the digital development of tools for a specific area. And so the overarching framework of the Smart Guidelines is divided into 5 key layers. So the narrative layer, which is the clinical content that we see right now that's published by WHO. So these are often PDF documents with narrative recommendations. They're quite difficult to interpret by anyone who's not a policymaker. And so we're working with our teams who conduct the systematic reviews and the expert panels for developing WHO guidelines to make it a bit more digitally friendly and see how we can actually improve kind of the specificity, precision of the clinical guidance to begin with. And then the Smart Guidance content we focus on publishing right now is really this operational layer, so the digital adaptation kit requirements. So these are human readable software requirement documentations that basically describe how a digital tool should function in a way that allows for the health program team, so someone who maybe isn't familiar with any digital technology, to clearly articulate what their requirements are. And then it also provides that baseline of human readable components to then inform the third layer, which are the machine readable components, which I think is probably of more interest with this group here. And they're essentially FHIR implementation guides based on the Clinical Practice Guidelines IG that provide the clinical decision logic and data requirements that have been outlined in the digital adaptation kit into IGs, essentially, that are software agnostic and adhere to the HL7 FHIR standard, and then leverages semantic standards like ICD-11, HUFIC, and other open semantic standards. And so this, of course, is where we hope the actual interoperability pieces will come in. And then at WHO, we also support a lot of countries that are low income. And so we have executable components that are intended for supporting countries' adoption of the Smart Guidance work. So these are things like terminology services and product catalogs. Again, probably not so much an issue with countries like in Finland and high income settings, but in a lot of countries we work in, this is something that we need to provide as a way to help support adoption of digital tools in general, but especially with Smart Guidelines. So we have the executable Smart Guidelines layer. And then the last layer right now, which is an early piece of work right now, but of course a lot of interest for stakeholders, is the dynamic guidelines. So how do we actually leverage AI to not only be more locally relevant for each use case and have more kind of dynamic care plans, but then also use this as a way to inform us about the research gaps that are needed within the clinical logic themselves to inform the narrative guidelines. So this is more of a loop than kind of a straight line of the framework. So we see many scenarios of use depending on a country's digital maturity. And we also expect this to help inform countries with weaker governance standards to help establish a way to govern digital technologies. So the Smart Guides provide that shared language, of course, but then in doing so, it provides a benchmark for standards within countries. It reduces, hopefully, the time to develop a lot of these tools and times and resources that are limited. And for maybe more mature health systems, really allowing for the update and alignment with existing WHO standards and guidelines, including interoperability. So as WHO clinical guidelines are improved and updated, we want to have a shorter pathway for adoption into the point of care, rather than currently it takes around 2 to 4 years to do so at the minimum. So we want to improve that whole process end to end. And just to go through an example of what this looks like, we have quite a number of smart guidelines published right now for different health areas. It is published in a siloed manner, but that's essentially how funding works right now within WHO. So we hope in the future we could have a comprehensive, integrated kind of care package and the smart guidelines that aren't siloed into different health areas like antenatal care and immunizations. But unfortunately, that's kind of the constraints we work in right now. So just an example specific to the immunizations use case, we have a large amount of guidelines and summary recommendation tables for the actual vaccine schedule, but then there was also recommendations on a personal vaccine card, and then also the facility kind of data management. So how do you actually program, manage, and understand what the coverage indicators are? And so we pull all these recommendations, or what we call the L1 narrative guidelines, into what's called the digital adaptation kit. So this goes back to the requirements document. It contains the health interventions and recommendations. So that's pulled from the L1 guidance, generic personas and user scenarios. So this goes into the human-centered design aspect of things. This is where we expect countries to really adapt and create their own user personas and scenarios based on the context. We provide workflows, again, standardized, but we expect countries to have minor updates based on their context. The core data elements, decision support logic, and scheduling logic. So in the context of immunizations, it's what data needs to be collected to inform whether someone should be immunized now or later, and then whether they have any contraindications, and then also how to collect data for the purposes of program monitoring and coverage indicators. And then the decision support logic and scheduling logic are pretty straightforward in that sense. And then, of course, the indicators and monitoring, how to actually use the individual level data to calculate aggregate indicators and the functional and non-functional requirements we would expect to see in a point of care system for immunizations. And then we have, this is just what it looks like for the generic persona. So again, very high level, but we expect countries to have more specific versions of this, they're context specific. A workflow using the BPMN standard, and we try to stick to swim lanes that are BPMN adherent so that it is more easily readable across all the different health areas. And then we indicate where in the workflow there's decision support logic and data collection requirements. We have the data dictionary that's in a spreadsheet format, and a decision support logic currently in a spreadsheet format as well. And we are exploring ways to see how we can make this a bit more computable and user-friendly, but going back to the current constraints, the spreadsheets are the most easily accessible right now. And then we have the indicators also provided in a spreadsheet format. And again, it's intended to link all the individual data straight back to the data dictionary, and having the semantic standards encoded already as well. And then a list of functional and non-functional requirements. And then, of course, going back to my earlier point about how design still matters, we do not provide any sort of UI recommendations of that sort, because we recognize that that's highly context specific, and there is a difference in terms of who the end user is, if it's a highly skilled worker or a vaccinator volunteer. And so we don't provide any of this, but we do provide all the required data that should be standard regardless. And then, of course, the machine readable component, we translate all that information into the FHIR IG. So we have logical models to help support the mappings, and then the various clinical decision support logic using CQL. And then we see this as a new way to help we support countries develop tools for digital health. And so currently there's a lot of siloed tools that are monolithic and proprietary in a sense where it requires custom integration across all levels. But we want to move it towards more of a building blocks mechanism where we can provide the standardized data model and the app logic and the clinical logic for each health area, but then the tools would be designed and more focused on how to make it easier to use for the health worker instead of focusing on the other areas that should be standardized already. And this is just an example of what it would look like in an executable application. Again, this is not something we want to produce moving forward, but just to show kind of what the end result can look like. So this is just an example of immunizations data showing up in 2 different kind of apps. So just to summarize, the smart guidelines layer are really intended to provide tools and documentation for countries so that they can adapt as needed. But then it also provides that benchmark for countries that maybe don't have a clear idea of what's needed right now to be able to adhere to the same standards as everyone else. And smart guidelines really are just one piece of guidance documentation that we provide as WHO. So we provide other handbooks around how to do digital transformation for primary care, how to invest in digital technologies, and the smart guidelines are really focused on providing the health content requirements. So just one aspect of this as well. And so they're not only about digital, and they're not just kind of one output of the smart guidance. It's really this whole suite of documentation, but then also a methodology to really how to document digital interventions and support countries in their governance aspects of their digital health solutions. And then we also hope that they will eventually help facilitate identifying gaps in the science and existing clinical guidelines as we go through this process in and of itself. We've already seen certain gaps in kind of the recommendations that are coming out of WHO and also other guideline and entities. And so we're hoping that this methodology in and of itself will help improve that process. So we also see the smart guidance facilitating the transition to having more patient-mediated data exchange, where we have a standard, so using FHIR for the facility-based or health worker-based tools. But then if we use the same standard for individual health records, like a personal health wallet, combined with the verification tool of the Global Digital Health Certification Network, we hope it provides this whole ecosystem of kind of guidance for countries to then enable a future where everyone has a personal health record. And to quickly note on the Global Digital Health Certification Network, so this was a legacy of the EU GCC tool, so the tool to help verify COVID certificates. So in 2023, WHO took that on from the EU and then expanded the use from COVID-19 to other use cases. So right now, specifically, we're exploring how they can be used for pilgrim health records, so like for Hajj, but then also more pertinently for the yellow fever vaccine certificate. So the International Certificate of Vaccination Prophylaxis, which is in the response to the member states wanting to update the international health regulations to allow for digital versions of the health documents outlined in the IHR. And so we foresee every country having their own software system as they need, based on their own governance structures, their own certificate issuance softwares. But then if they all adhere to the smart guidance standard, the technical specifications that are needed, it'll also facilitate bilateral verification through the GHCN. So individuals can have access to their health information regardless of where they go. And so we have a large community of partners. So if anyone is interested in joining them, we have calls every Monday at 3 p.m. So this is more focused on the machine readable components. So discussing how to author the machine readable guidelines and implement them. And then we also work with Google Health, who hosts the bi-weekly developer calls for Open Health Stack. So using and developing the Android software development kit to adopt the smart guidance content. And so that happens at 2 p.m. Central European time every 2 weeks on Thursdays. And so if anyone's interested in joining, feel free to just email us at smart@who.int. And that's it for me. Yeah, happy to answer any questions that people may have.
Thank you very much, Natasha. Because of the audio situation, if you have any questions and Natasha can't hear you, then please just come closer to the podium and ask away.
And apologies, I can't seem to turn on my video, so not sure what's going on there. But yeah, if anyone has any questions, please let me know.
Seems like we're in a post-lunch slump here, but or maybe your presentation was so exhaustive that everybody got everything straight away.
I find that part hard to believe. It's probably more the post-lunch slump.
I would wager on that as well. Once again, thank you very much for the presentation.
Yeah. Okay, great. Thanks, everyone.
Thank you. So the next presentation will be at 2 p.m. We don't need to rush there currently, so let's spend some time hacking until then.
I'm here. I forgot to say I'm here also as part of the Share team. I was invited here. My company is Ericsson Nikola Tesla from Croatia. I'm product manager of Ericsson clinical decision support system, and I here represent my product team for CDSS. So what I have to say, it's a young product on a young market in Croatia and around us, and we try. I would like to emphasize we try to solve the everyday pain points of our customers. So, as Ericsson Nikola Tesla, I'm here also presenting a national integrator and provider of national fire infrastructure, and also I am presenting a product that is on the market, and those are two different perspectives. So when you have a product, you need, in order to sell the product, you really need to solve the pain points of the people on the field that are of GPs working every day with clinical decision support systems. So from that perspective, your product needs to be polished, it needs to be user-friendly, it needs to ship fast on the market and stuff like that. So we experiment with cool things in my team, and I will present something that might be good or practical to use AI for. So Jonathan sent me OPD guideline. It's Finnish, but it's in English, so it's good. And the idea of this cell-phone is to convert it from L1 to L3. I have somewhere for you who don't know what's L1, what's L3, okay? So L1 is the unstructured, textual, let's say clinical decision, clinical guideline. And L3, we will convert to L3, is structured. And L4 is the level that we are going to execute and get some results. So I will turn to the.
Could you go back? I'd like to note something in the slide, please.
It's from Cologne.
Ah, okay.
So yeah, so this is what we are going to do here. Of course, you can have the other stuff, but this is. We'll try to structure clinical knowledge by using AI. Okay, so yeah, so we will create guideline with AI. We will create some SQL code. We will test code. We will check parts of the guideline. We will do visual test, and we'll connect with IH. So this is with my small EHR. So a few considerations. So this is hackathon terminology, and that stuff is beyond the scope. It's also beyond the scope. Who is the author? Is this AI or a person needs to be age, whatever. So just a quick note. My idea, and I believe that something that's important, that AI is here, and we need to use it together to create something that's maybe better. So when speaking of AI in the real world, and we need to be aware that that elephant in the room, and although we have FDA-approved CDSS tools and everything is regulated, we have this elephant here. Well, it's a chicken, but let's say that. So that is something really important to consider, that people are using every day. They are using cell phone, asking ChatGPT the guidelines, providing some patient input. They are doing everything on their cell phone. So now ChatGPT has become also some kind of regulated healthcare device. Also, in terms of America, the USA, FDA, some, I don't know, there is now ChatGPT for healthcare product. So, okay, so what is the possible power of good integrated clinical decision support systems with different systems? Where we can trick the ChatGPT, it's not part of this session, but we can create good integrated system that gives the right information to our clinician at the right time, so that he or she can skip using for 5-10 minutes using ChatGPT on the cell phone. And there is a lot of steps to come to that. Okay, so this will be more like a hackathon. I will hack. I know that I haven't prepared some other things to say to Jonathan what I expect so that people can also hack. So I will be using Windsurf AI code editor. I have some tools for that we use in Ericsson Nikola Tesla, and now I have made and published. I have published them. They are not ideal, but they will be helpful in this session. I'm using CQF ruler or Happy 6.6 in a Docker. I will use TDS hooks to connect with Happy, and I will use apply operation to generate care plans, and I have my small iChair test application for visualization. And so this is simple architecture. Code editor generates the fire stuff. We have a CQL validator and one definition here to also validate that visually. We have CQF ruler or Happy. We have them up, and we will also use some small care plan here to see what is generated. Everything will be really simple. And so when you're working with AI, I would say there are about 5 rules that I would like to emphasize. One is to know your guidelines. So you need to know what are you doing. So that's really important. You need also to have your canon. So you need to have your rules, how AI should work, how should generate your guidelines, your CQL, and I would say this is the most important rule. So this is hackathon, and of course, maybe you will hack at home or tomorrow, whatever. And this is all getting much complicated if we put that in a real productive system. So, but these are some rules that are applicable to the both sides, hacking and to the real. So, yeah, we need to be in control of our LLM. Okay. We need to know also the basic of the standards. For example, LLM will generate some CQL that's hallucinated and has some errors. You need to know the errors and to fix them. And you also know the output. You need to know what output will be. Okay, so just for the hackathon, you need to start simple and build up that decision tree and whatever. So, okay, I would also suggest to have multiple small simple CQL codes, files, and okay, just to have everything working and then build up with and validate and test. That's the cycle. So yes, this is what writes here, and when you do that, restart Happy regularly to clean the cache. Okay, hands-on. So just is there. So I will try to do it in. Okay, now I will try to start hacking, and maybe it will not be in this another 15 minutes, but I will first mute myself. Oh, I'm good. Okay. Okay, let's create some. Let's start. Here. Jonathan sent me a link to the. Jonathan sent me a link to the guidelines, so I will first start. Okay, let me just take one. just take, this is the stuff I generated. I'll just take the OPD guideline. Okay, so this is markdown of our COPD guideline. And if you are interested in the guideline, it's, I think, somewhere here. Okay.
It's the blue D icon you have on the left.
Yeah,
There.
okay. So this is our guideline. The good thing about this guideline, it's pure text. So it's pretty easy to put it in LLM. Okay, LLM can understand also images and stuff like that, but this is much easier for us and we can be more assured that everything will be running much better. Okay, so first thing is to read my I'm using the GPT codex fast, so it's really good. Okay, so let's say that I will also put here my Canon. It's here. It's my Canon bundle, but I have created even better one. It's not fair to put CoPD, but let's say I will take my rules and just copy the whole Canon in my case. So okay, I will ask him to read the whole canon, my guidelines, and my rules. I have here some rules. They are pretty basic, but they are explaining for this basic tutorial. They're explaining what I would like to achieve. So I would say that most important. So when I brought here my rules, let's say from my using traditional on art, how we define our clinical knowledge. And when I started working with Happy, it's pretty much different. So I needed to adapt the rules to the how Happy implements our clinical reasoning. And now, okay, rules are the source of the truth. And based on that, let's try to see what this. Okay, list me inclusion area. And I want you to generate, I want you to generate simple, how it's called simple, simple, okay, simple, or, okay, simple guideline. Check. Okay, we will use SnowMet. We will use SnowMet. Okay. And that will check little patients with heavy smoking stuffs. So I will build just a simple guideline that will take into account if patient is a heavy smoker, and then we will generate plan definition and activity definitions and see what will think up. Which is smoking stuffs. Yeah, that's from other source. Okay, I'll let you show you the tools that I'm using. Okay. Yes.
Also, smoking status code itself.
Sorry?
The smoking status code itself. It's some resolution. It's like this will be in the value, but what will be the code?
Yeah.
I guess it's
Yeah, good point. I will ask it to put it in. So I will use it as an observation.code. I will use it directly in the code. I will not use it just for the sake of simplicity. And so what I hope expected output will be is so it's here, but it will be residing in the code. It's much simpler for me not to create some complicated CQL. And, okay, so let's. Oh. Yeah, he presented what should be. Okay. So I will ask, and
it's in the wrong window.
Yeah, wrong time, wrong context, session, session. Yeah. So. Observation code. Okay, so now I would. So. Okay, I want my right line to for the smoking status and suggest patient to. So I will create simple guideline that will detect smoking status and create service request for the spirometry. And yes, use my rules, use my name, some event from rules and qualification. Create new folder. Okay, so let's see what will happen. And while okay, he's something, and let's go to the simple tool. It will visualize what this. What should the folder name be?
Yeah, very specific rules. So it's
So it would be much easier if I have already put my previous session, but now I'm building from the whole new session, new context of the AI, and let's see what will happen. Okay, he's asking to me to. Oh, okay, yes. Okay. Building a new folder. Okay. Okay, let's see what this. Okay, right. why he's asking he shouldn't just ask him for it, he would just need to generate the files. So it's I don't know how he's trying to generate files by using PowerShell. Usually it's just define files normally. Don't worry, if everything fails, I have saved my previous files from previous sessions. So we will just load that to the, and let's see if these are. Each data doesn't. So he asked me to do base 64 coding, but I don't want him to do. I will do it manually. So when LLM starts working with base 64, it's I'm not happy with it. So I would like to control it. Okay, now finally it's starts appearing. So like this, but it's not good. But let's accept create secure file. Create also file. So let's see what it will create. So my SQL code is here and it's not good. So that's the point you need to know your code. And this is my small code tester, and it's pretty good. I don't need everything here. And let's say just heavy smoker. We will do this. Where exists use that. Where exists which there exists. Just okay. Okay, and let's convert this to the ELM and see what will happen. Here I have some test patient that is heavy smoker, and let's see if it works. So this tool is translating SQL to LM by using the WASM or in-browser technology. So it's not using external service. It's pretty slow, but it's good for. And probably it says there is some effects in my. Yeah, okay, so, but it's good. Okay, so this patient here is heavy smoker, and now I can see that it's okay. So if I run SQL, I get heavy smoker too. So that's now I will use this. I will use this for my SQL. Okay, let's say that. And now we have also bundle. Let's see what happens inside. Or maybe I should say I'm not interested in what happens inside. I will try to visualize. So let's find my file. Mm. Okay, so this tool is pretty useful. So what it does, it shows our how structure of our clinical guideline is, or basically it's a plan definition here. And in my company, we call plan definitions CDS services. So for the people who don't want to talk about fire naming. And here we see the condition. If person is heavy smoker, then this clinical guideline will take action. And this child, okay, this is child plan definition. So our structure in my company is a little bit different, but and if it is heavy smoker, of course, then we will order spirometry and we will get some kind of fire service request. Okay, so I think this is good. I'm not getting into details of what is generated here to visually check every JSON attribute. So I hope it's created according to my canon law, and I'll just check one. I'll just check one thing. It's missing. Check ability, and I would like to check my application. Okay, well, let's keep that important stuff. Okay, this is my monitor. We are now seeing something. And now we will send this bundle to the fire server. Okay, copy. And here we are at there's still one thing we need to do. We need to put base 64 CQL here. So it's what I will do. I will take my CQL. Sorry, this is really pretty fast and it's a lot of switching, but let's try to do something and then later I can maybe explain and talk a little bit more about this stuff. Okay, I'm copying this.
For the next iteration of the demo, you will create an MCP server where you can send the text and it returns the base 64 for you.
Yes. And let's paste this in our execute. I hope it will be okay. Yeah, it's too much. So now we are going to my small test app. It's now empty and I don't have patients inside. I would like to create a patient. Let's create some test. It hurts. Okay. It created. It should be. It's handy to have your own test apps that will visualize what are you doing. So now this is broken and I know why, because I stopped the app. So let's find it again. EHR client. And this is Svelte app. I like Svelte. Yeah. Okay, I have that. And let's simulate some workflow. So let's create a counter and well, I will put anything. So it's a new encounter. And for some reason, encounters took some time to create on Happy server. In the meantime, I will just check what is happening on.
How much time is that time when, for the encounter creation? Seconds,
I
how?
don't know, it should be immediately, but for some reason, I don't know, it's.
Because when we ran into similar issues, it was a cache on the searches on the server. So we pushed in we first searched for encounters, there were zero, then created it, and I searched for it again. And then it just returned a cache search result before the creating. So maybe it's some happy fire configuration that can.
Probably, in my everyday work, I use our custom file server and, but now I'm experimenting.
It should be.
Yeah, it's much, okay, encounter is here. So, more than this yellow is because of big share. And now we see here some CDS services. So what this thing does, it discovers CDS services on our Happy Fire server, and let's see what will happen. And I will just test the patient view, and probably nothing will happen. And let's see. Okay, so it called CDS, but there are no cards returned because nothing is and okay, I will call this CDS service, and I will add some observation for this patient and tobacco smoking status. I will take this. And I will hack it. I will add it as observation code. And now we have our heavy cigarette smoker. And let's call our CDS service. Okay, so what we have here is a CDS card, which is rendered pretty awful. And it says order spirometry. And it's a problem because I need some additional stuff inside. Let's see what's happening. I will use I will use this tool here just to check my services. Okay. Is order spirometry. Let's check. And it's patient number, ID is 5. Okay. Okay, so what's happening? The CDS service is executed, but I don't have any CDS card returned. That is something that I was looking in the code in the beginning. So it didn't generate the thing I wanted in my rules. So just let me check that. Holding account. I just look here. Okay, that's the canon. Why you need canon? You need to compare the stuff you get from the with your canon. I need to find something in one definition. Okay, this selection K. It's not present in my rules. Okay. Not present in my CDS. Okay, so selection behavior in my bundle. and let him fix. Usually you need to do that alone to be sure, but let's leave that to AI. One. And okay. So it didn't follow rules in my camp. That's the problem. So but I think that AI is trained on I can see that AI is trained on the human content because the human usually break rules. So probably he learned that it's cool to break rules sometimes. Okay, accepted. And let's push this one definition again to the server. Okay. And maybe it's already. Oh, okay. So now what you see, this thing has returned to me action, and now I have service request to send this patient to spirometry, and I'll have this button here. Okay, and now we can send this patient. We can create the service request, and we can order spirometry for this patient. Okay, this is the first part of our tutorial. We just wanted to show how we can create, how we can structure unstructured content in a really, really simple way. If we have more time, we can really build this thing with more and more stuff, and it's not the idea of this hackathon. So now we will go to the final part. We will ask AI to create, so what when patient has COPD, and what are the steps to do. So I would like him to create a care plan that can be used by GP, by patient. So let's see. Okay, now the second step. I need you to create that relates to audience who have COVID. So please refer to the guideline and propose a new PD for PD patient. I would like you to create simple OPD pathway for treatment. So let's see.
Sorry, I just did say which version. It's cool. So 3, 8.
Same as okay. Okay, so back to our desktop, we can see that this patient who is heavy cigarette smoker now has service request to do spirometry. So in a normal life, we would send patient to spirometry. We would have a guideline that will check the data of spirometry, but now we will just go in more simple way. We will create condition that is COPD, and we will just add that condition to the patient. So now we have COPD patient, and then we will execute this next guideline. Okay, let's see what happened. First, okay, it's good. Good. Let's test this SQL and convert it to JSON. and then we will run it. Let's see here. Okay, so execution result is that the test patient has COPD true. Great. Okay. Now let's see what is the other stuff. Okay, this is accepting. I accept everything. And let's see our bundle. And it's here. And even as before, we will take this. We put it to base 64. Oh. We will create. Password. Let's put our and let's also visually check our other guideline. Okay, so we have this guideline. Let's check for CQL, SOPD, that's good. SOPD, SOPD, this is all good. So we can go with this guideline. But this okay, let's paste it out. Sure, is this the right one? Let's put this into the good. So let's hope that final step will work. So now I will refresh this, and I'm still on my encounter. Working because of force policy. So we have some new guidelines, new CDS services. We will click this one, and we will click generate here. And it said save one care plan resources. So what it did, what let me see, will care plan show. Okay, so when I click generate care plan, it created care plan here. And if I click on the care plan, I will see is it good. It is, let's say it's okay. No, no, it's not. It's my property treatment page. This is the one I want. So what generate care plan does? So call patient view calls CDS service of the public server, but generate care plan it calls my function. So we are now applying this plan definition to this patient through the application, and let's see what happens. Now we have two, and oh, this one is much larger. And now I will do one last thing. I will download the care plan and share it with tick share button, but unfortunately I didn't have time to implement sharing with tick share buttons, so I just mock it with the raw download, send to another file server, or share it via smart file link. So that is the next step in our workflow, but to conclude this tutorial, let's see our care plan. It is in downloads, I think. Okay, so our care plan 17 is not good rendered, but okay, so this is our care plan. It says, okay, you need to see some smoking counseling, you need to do physical exercise, and you need to do this therapy. And because I have read the guideline, I know that is in the guideline. And now what is the part of care plan? It's one communication request for counseling, to have a smoking counseling session. And the other one is also communication request to get some recommendations for physical exercise. So if I return to my presentation, so we have done the full cycle. We have read the guideline with the editor. We had some rules. We generated CQL, plan definition, activity definition. We fed everything in our CQL rule, or happy. And with our demo application, by using CDS hooks, we have did some CDS services. And also by using the apply function, which I didn't put here, we have generated care plan. And now the final step was to load care plan in Bureau, or if you want, in some kind of application on the patient side or physician side. And now the idea is to put that care plan in a practice and to do everything. So I managed to stay inside the time. Sorry for a lot of context switching and stuff, but I think it's a good point to show you how you can start maybe playing with your guidelines in a similar way. So thank you.
This was a blast. Thank you.
Oh, thank you.
I played with vacation guideline while we were doing this, and succeeded. It's different.
Yeah.
So it was very good. But I have two questions though. Number one is that when you're using the Snowman CT, you get you didn't get correct. Yes, you get correct smoker
Yes.
concept, but if you just ask a language model about the concept, it will probably suggest something wrong. Have you connected to a terminology server, or do you have some kind of terminology definition within your code here?
No, it's just as it is.
Okay, then you're lucky. So good, because we have connected it to the snowstorm terminology server in order to get it right.
Yeah.
So it tends to, just create a random number, so to speak. That's number one. Number two is, I think there is a huge value here. And I do agree a little bit with what you said this morning, that there is no need for structured data anymore because AI is everything. That's false. That's a false narrative. I'm one artist where I've been working for this for years and nowhere now. You need structured data in order to make the AI perform as supposed to. So it's even more important. But we were talking a little bit about the medical device regulation, MDR, and CE marking as well. And I think this will be deterministic, right? The opposite as if you're using a large language model as the primary source of decision support. But how do you quality assure all the rules you build into this? You still need to have human in the loop, right? To review these rules.
Yeah. So this is hackathon, and in practice, how we do at this moment. So. That's the important thing was on the beginning. We are also a product company that is on the market. So we come to hospital, and when we start talking with clinicians, and then the thing start to be a little bit more different. Some of them want some part of the guideline, some of them want just to give me textual guideline. And then when you see what the market really wants, and the market are clinicians in hospitals or whatever, then you see that you need to do a lot of adjustments. So how we do? We usually start with hospital who is interested to form like concilium for the guideline. And then let's say that at one moment we will present this kind of guideline that we built at my company and start working with them that I will have session tomorrow, how we do the altering stuff, how we do it in Create with our system. So somebody needs to sign.
Yeah, exactly.
So we are just using, at this moment, we are not using AI to create real world guidelines. This is something that I would like to do, and we will probably use this. I think it's rational. But you are controlling. So you need to control the thing, you need to check that. That's the reason why, for example, in my company, one of my colleagues, she has a PhD in medicine, and she's the person that will review everything that we create from there.
Exactly.
And then she knows how to talk with clinicians. And I think that kind of person is really important to have in your company. And so we will adapt to this whole stuff.
Great. So this will make the process of creating these rules way more efficient. For sure.
So, okay.
Thank you.
Thanks for the presentation. One thing I was wondering, this canonical stuff that's there. Yeah. So why did you use JSON schema file? What does that mean there?
I haven't tried. Maybe it would be, but so I learned when I code with AI that I constantly write. I ask AI to generate documentation in Markdown. Somehow AI really works with it, Markdown, and I haven't tried.
Yeah, no suggestion. Might be a good idea. I don't know.
Maybe even in some other like rules definition of language, something like that. It's
The relationships with
you're not did you raise the hand?
No. But I can comment regardless, because one thing why I found this presentation interesting in the first place is that, for example, the guideline that we used, or part of the guideline that we used as an example here, that's one of a very large set. So we would have like easily over 100 guidelines. And one thing that has been a big blocker for us at Duodecim thus far has been that sort of scale. And I think that tools like this and ways of working like this could be a way of getting that process working a lot more quickly. Because from the discussions I've had earlier with various people involved in the CPG like space, it's not like unheard of that even updating an existing guideline can take the like guideline development group months. And that's certainly true even just in the clinical sense. And of course, that's not a technical issue in and of itself. But adding to that the whole like informatics side of thing without having some sort of AI assistance or some other sort of neat way of introducing this kind of translation would be a huge ask, I think. So anything that can make that process easier, I think, for people like or groups like Duodecim, right, who's like mostly about authoring the thing, like making that informatics step easier is definitely, a plus.
So my context is different than yours. For example, when I come talk with a clinician in a hospital, he or she asked me just a small piece of guideline that she would like to have triggered with CDSS. She knows the guideline, but there are some things like calculators, like this, like that she wants to have in CDS. So, but when you implement, let's say, national guidelines, then it's a whole different story. then you have that huge guidelines, problems and stuff like that. But when you go on the market, you see really different situation within different personas.
Mhm.
Yeah, just one question. Have you have these guidelines or something that uses the CE mark as medical devices?
Okay, so our product is now our clinical decision support system is in process of getting MDR. So we had a discussion with companies that are providing MDR accreditation and stuff like that. So we try to have conversation. Is it CDS, like a mechanical program, should be MDR regulated, or the clinical content or guideline that is created? So what should be under MDR? And basically the thing is similar like if you heard for medical imaging and DICOM images. For example, DICOM image has a clinical relevant information, but the software that reads DICOM image and software that is presented to the clinician or radiologist who writes reports should be MDR regulated. So the software itself needs to be regulated, and basically it's not so much important what is the content of guidance, but I think it should be also important. So, but probably the thing is relating to that guidelines are created by through the science, by relevant authorities, people, and yeah, it's complicated question. And
I think it's the implementation of the guideline. See, because of course, if you just bring the guideline, then it's up to the reader. When you are running a computer, then even the guideline becomes simple, then it becomes see what medical device.
yes, but in that case, you should somehow put a CE mark on the process that creates guideline, not guideline itself.
I found it.
So I don't, this isn't exactly the same, but I know we have been banging our heads against that same or a similar wall when it comes to SDC questionnaires, because that's a case where there could be even something like a BMI calculation or whatever, anything that has that sort of firepath thing that creates some value. And, you know, here too is the same question that Ivan raised. Okay, is it the fire questionnaire that is the CE mark thing, that content, or is it the form filler application? Or is it the combination of those two when you put those two together? And so far the consensus, I don't know if there is a consensus, but it seems to be like the worst case. So whenever you put the content and the application together, that's the thing you have to CE mark.
But what have you read? I have seen that you have CE mark.
Yes.
I presume it's for software itself.
It has to have those things, even the content as a part of that, within that regulated thing.
Yes.
So it is intended use.
Yes. So at least we haven't been able to convince the regulators that, okay, it's something that deals with SDC questionnaires and somehow certify that, or even certify the content somehow separately. Like it has been the product of those two thus far. I don't know if it's the same in the guideline space, but at least for questionnaires, that's how it seems to go today. Yeah.
There is, I think, that didn't come over here, as tomorrow with the snows off. Some things over the. And so here we can see goals. Wolves.